So it's been a couple of years since I've been here. I don't think I've been here since before COVID. But I used to come for a few years in a row. So it's good to be back. The room feels bigger than the last time I remember. I don't know if you guys have done any remodeling, but anyway, I came in through the back. I didn't realize that I was like walking directly into the room. But I am from the Valley. I'm from McAllen. Went to Mac High. Any Bulldogs in here? Any Bulldogs? No Bulldogs at all. Oh my goodness. Okay. Well, I did go to UTPA, graduated in 2006, and then eventually came back over here. And I've been here since 2016. So it's been going on 7 years now. It starts to feel funny when you start seeing all these patients coming back for their second colonoscopies, or due 5 years later if they have polyps. So starting to feel like I'm getting a little bit older. But it's, again, I'm really happy to be here. I like to speak with students, and I always say that I have a lot more fun speaking with students than I do with other physicians, because I feel like you guys are still brand new, still fresh, still excited about learning new information, and you don't know exactly which direction you're going to go yet. Today I'm going to talk to you guys about inflammatory bowel disease, and we see this it's an extremely common disease process. At least in our office. It's not common in the general population, but we see it all the time in our clinic. Ulcerative colitis way more often than Crohn's disease here in the Valley, but yeah, we see it pretty frequently. In fact, I just diagnosed an ulcerative colitis last week. We'll probably see one, but once every 2-3 weeks, so pretty frequent. Let's see. If I just click this, yes, okay, good. So I shortened this lecture compared to what I used to do. I used to do four cases. I shortened it to 2 because I remember, I would get through 3 lectures and there'd be like 5 minutes left. I try to rush through the 4th one. But rather than go through 4 lectures, I decided to cut it down to 2. And then, so I'm going to give you guys the information, and we'll kind of go through it slowly. And you guys try to think about what this sounds like. Does it sound like inflammatory bowel disease? Does it not sound like inflammatory bowel disease? If it is IBD, is it Crohn's disease? Is it ulcerative colitis? And we'll go through the differential and the reasons for it. And at the very end, I added an extra lecture because, like I said, it's been a while since I've been here. There's some new medicines that have come out in the last several years. And so we're going to go briefly over those. So the first case is a patient that I saw a few years back. So it's a 28-year-old Hispanic male. And the reason for the consult was for rectal pain. So in the GI clinic, we frequently see rectal pain. We see heartburn, bloating. I mean, 90% of the time it's like bloating, heartburn, diarrhea, rectal pain. So just hearing rectal pain, what would you guys say are the possibilities? Hemorrhoids? Perfect. So yeah, so hemorrhoids is far and away, like if you were to bet money, a 28-year-old patient, rectal pain, thrombosed hemorrhoid. And so when we talk about patients that when you walk in and patients are sitting on their side, to me, whenever I see that, it's one of 3 things. It's either fissures, thrombosed hemorrhoid, or an abscess. Always one of those 3 things. If they're walking in, they're like laying on their belly or they're sitting to the side, immediately it's going to be one of those 3 things. But this patient, when I walked in, it was in the ER and they were laying down, so I couldn't get that information. But yeah, so hemorrhoids is one. Again, we talked about fissures. We talked about abscesses. What are other possible causes of rectal pain? What was that? Sure. Yeah, rectal prolapse. So that looks like a little inverted volcano. I don't know if you've ever seen those rectal prolapse. The first time I ever saw it, it was at Parkland, and I walked in. If you've never seen it before, the first time you see it, you're like, oh, holy cow, okay. So yeah, so rectal prolapse is another one. And then, if patients have had diarrhea and they've been wiping a lot, it's like rashes, trauma can also cause rectal pain. So moving on. This patient's reported 1 year of pain in the rectum, and it's gradually been worsening over that time. He says he feels a lump, and when he touches it, it's extremely painful to touch. So much so that he has a lot of trouble going to the restroom. When he tries to go to the restroom, it's very, very painful. He says it also hurts a lot when he's sitting for a long time, as well as when he's walking. When we talk to him about, what other symptoms do you have? He says, well, I've also had a lot of diarrhea recently. You ask him about fevers. He says, yes, I've had some low-grade fevers, chills. And he's also lost some weight. He's lost about 12 pounds in the past 6 months, and he's become progressively fatigued. So one other thing that I always talk to my patients about is that, here, especially here in the Valley, but in general, it's hard enough to lose weight. But when you're losing weight unintentionally, there's always something else going on, and some patients will try to play it off and say, no, I've been eating a little bit less, but it's really hard to lose weight, and so especially for a 28-year-old Hispanic male, like there's really no reason to be losing 12 pounds, and so you have unintentional weight loss, you have diarrhea, chronic diarrhea, and then you have this painful lump in the rectum. So past medical history. So we'll go ahead and tell you guys he was diagnosed with IBD in 2009 back in the U.S. But because of financial constraints, didn't have insurance at the time. He went to Mexico. When he was in Mexico, he had a colonoscopy and was reportedly diagnosed with inflammatory bowel disease. He said he had a colonoscopy in 2014. At the time that I talked to him, he didn't have a colonoscopy report available. He said that up until then, he'd only been taking intermittent steroids. But the last time he took any kind of treatment was in 2014. And then just going over all the other history, social history, surgical history, family, really nothing of note. No history of colon cancer, no history of autoimmune disease, occasional drinker, but really nothing drastic. So when we examine him, he does have a low-grade temperature. He's 100.1. He's pretty tachycardic. And again, this guy is a 28-year-old male. His blood pressure is 98/55, and you would see that maybe in a smaller patient, maybe an older patient, but in a 6'2", 28-year-old male, that's a pretty low blood pressure. He's also 143 pounds, so it's a BMI of 18. So he's pretty underweight as well. And he looks like it. When you see him, he looks chronically ill. He also looks acutely ill. So he's a little bit tachycardic, a little bit tachypnic. He's got cachectic appearance. And he's just not looking comfortably at all. When you examine his belly, he's got moderate tenderness throughout the abdomen. He's got voluntary guarding, which means you get ready to touch him and he stiffens up pretty quickly. He does have bowel sounds. He's not distended. So if I were to go over to him and I see him and he's just massively distended, tympanic, what would be one of the first concerns that you guys would have? Yeah, either bowel obstruction, perforation, so peritonitis, basically, right? This guy did not have that, but he was tender. And then when we checked his rectal area, he did have some purulent drainage from several perianal openings, very tender to palpation. And when you pressed on these openings, there was some fluctuance noted. And he also had a large skin tag protruding from his anus. So going through the labs, he had a leukocytosis, white count of 13,000. He's a little bit anemic, but more significantly, he's very microcytic. So microcytic anemia, what do you think about with that? Yeah, so iron deficiency. Whenever we see anemia in clinic or in the hospital, if a patient's coming in with rectal bleeding and they have a normocytic anemia, we think that there's maybe something more acute going on, maybe a hemorrhoids, maybe a diverticular bleed. When you see something like this where they're very microcytic, you think that they've been having steady blood loss for a long time. And his platelet count's also pretty elevated. It's 534,000. So that's an inflammatory marker. So he's got some inflammation going on. This has been going on for a long time. The rest of his labs, LFTs all look pretty unremarkable. BO and creatinine ratio is a little bit elevated, so he's a little bit dry. And his CRP is elevated, so it's 14. So he does have some pretty significant inflammation going on. We did check his stool studies to make sure that he didn't just have C. diff or another infection. Everything was negative, and blood cultures were negative as well. So we got a CT scan. And most important thing is it mentions what looks like an abscess. So a low density collection. The abscess measures about 10 centimeters by 4 by 1.6. So pretty big. And then he's got multifocal areas of wall thickening scattered throughout the colon. So when you hear that, so areas that are scattered throughout the colon, so it's not continuous, right? So you have wall thickening that's in different parts of the large intestine. They don't say it's continuous. And then they also mentioned fatty infiltration and adjacent fat stranding. So that means that whatever's going on is going on basically through the wall of the colon. So what do you guys think about that? Good job. So he was admitted. We started him on IV Flagyl, Cipro, and again, this was we're still waiting for some labs to come back, and GI panel hadn't come back yet, so he was empirically started antibiotics. But on day one, He actually went to the OR, and they discovered he had a perirectal abscess and fistula. On a CT scan, he got an IND, and he had some cetons placed. Day 2, he was recovering from his extensive IND. So we talked to him and we said, listen, we suspect you may have Crohn's disease. You look kind of uncomfortable. You got all these cetons in. You just had a surgery. Why don't we wait a day? We'll give you your laxative, and then we'll do the colonoscopy on day 3. So that's what we did. We did his colonoscopy, and this is what we saw. So he had severe proctitis, he had sigmoiditis, and then he had a bunch of areas of pseudopolyps. And if y'all, I don't know if you guys know what pseudopolyps are, but you go in and you see, if you do enough colonoscopies, you know what an adenoma looks like. You know what a hyperplastic polyp looks like. A pseudopolyp will look kind of like a funny shaped polyp. And what it is, it's just the remaining a normal tissue, and everything around it has kind of atrophied off. And so it looks like a polyp, but it's really just what's left of the normal mucosa. And he does have a significant stricture in the sigmoid, which we couldn't pass through with a colonoscope. And so that's always concerning. We took a bunch of biopsies. So after the colonoscopy, we called colorectal surgery because, again, we couldn't get through the stricture. And so one of the concerns when you see a stricture like that would be malignancy. Now, he's 28, a little bit lower likelihood, but regardless, if it's that stricture down, he has a risk of obstruction, especially if he's that inflamed. So we did put him on solumedrol. He was on solumedrol 60 milligrams IV daily. Day 4, fortunately, his pain was improving. He was starting to pass more flatus. He was having bowel movements. We discussed the case with colorectal surgery, and they thought that since he was improving, we just let him continue to improve. They would follow up in clinic, and there wasn't a need for immediate surgery. So he was discharged on day 5. All right, so I guess the way I'll word this is, why do you guys, what would point against ulcerative colitis in this situation? Right. So ulcerative colitis, you would see a continuous pattern, right? The other thing you would see in ulcerative colitis is that you wouldn't have this like fat stranding. So transmural inflammation is another hallmark of Crohn's disease. So he's 28, and it's not impossible to have colon cancer. I'm sure a lot of you guys watch TikTok. There was a recent famous TikToker that died of colon cancer. He was 35. I've scoped a couple of people that I know that were in their 30s or are in their 30s. They've had pretty big polyps as well. So it's certainly possible to have colon cancer, especially if you have things like Lynch syndrome. IBD is a risk factor for colon cancer. But again, possible, but a little bit less likely. Ischemic colitis, what kind of patient would you suspect ischemic colitis in? Yeah, so an older patient, somebody that's maybe like a vasculopath, somebody that maybe has CHF or recently started a blood pressure medicine, was outside in the heat working. So this guy's 28, again, less likely. And then irritable bowel syndrome. I mean, he may have also coinciding IBS, but it's not the main issue going on here. So as you guys said earlier, Crohn's disease is what he has. All right. So as we talked about Crohn's disease, it's a chronic disease process. You have these unpredictable flares and remissions. Diarrhea is usually what you see, but honestly, anybody who comes in with just vague symptoms, I always keep Crohn's disease in the back of my mind, especially if they've been having issues for years. They say, ever since I was in middle school, I've had these recurrent bouts of abdominal pain and bloating, and nobody ever knows what it is, and people just say it's IBS. And with IBS, a lot of times you kind of feel the phenotype, and some of the patients are anxious, or they have a history of depression, or there's more importantly, the labs are typically pretty normal. And so whenever you hear patients that report chronic issues with recurrent, what sound like flares, you always think about the possibility of Crohn's disease. And it can be really difficult to diagnose because for the most part, we can only see up to maybe 10 centimeters into the duodenum. We do a colonoscopy, we can maybe see about 10 centimeters into the ileum, but there's about 25 feet in between there that we just don't see up front. And there's other things we can do to look for that. But when patients are first being evaluated by family medicine, by their family doctor, by internists, that may not be the first thing that they think about. And so always something that I keep in the back of my mind. Malabsorption and weight loss is common, especially if it's been going on for a long time undiagnosed. Abdominal pain. So classic is right lower quadrant pain. Do you guys know why it would be in the right lower quadrant? Terminal ileum, perfect. Christina, you're doing good, Christina. I don't even need to be here. So yeah, right lower quadrant pain, terminal ileitis is what you would think of. And anytime I have a patient that's this age, who has chronic diarrhea, anytime somebody has chronic diarrhea that's a young patient, I always make sure to go into the terminal ileum because the entire colon can look totally normal, as we'll talk about here in a little bit. But if you go into the TI and you see a bunch of ulcerations, you can make your diagnosis. Patients can have fever, malaise, and then there's a lot of extraintestinal manifestations patients can develop. So what are those extraintestinal manifestations? So we don't see these all that often, but when you see them, it's pretty impressive. We've had patients who come in to the hospital and, they have diarrhea, and we're looking through their notes and there's mention about like patient looks like they had a spider bite and patient's going for IND tomorrow and patient denies spider bite and this and that. And it's not a spider bite. It's they have Crohn's or they have ulcerative colitis and they have these skin manifestations. But so episcleritis and anterior uveitis are a couple of eye lesions you can develop. Uveitis, you can have some pain. Episcleritis is pretty pain-free, but you do have some redness. So erythema nodosum looks like somebody just like nailed themselves in the shin. Very, very hot, very tender, painful lesions. And then pyoderma gangrenosum is what we were talking about, where just these big ulcerated lesions. Looks like you would think that they got bit by a black widow or something. And the treatment of these is making sure you treat the underlying IBD. So it's not incision and drainage. It's not debridement. That actually will make it worse. So you can have different types of arthritis. Ankylosing spondylitis is really is very associated with UC. Sacroiliitis, and then you have increased risk of thromboembolic disease. Gallstones, pretty common in Crohn's disease because of the TI involvement. And then primary sclerosing cholangitis. Just saw a patient yesterday, actually, who I've seen for a while now that we suspect he's got PSC. We haven't done a biopsy on him, but he's got MRCP findings that look suggestive of it. He's got some strictures in his intrahepatic ducts. He's got ulcerative colitis. So very common in ulcerative colitis patients. So patients who have a diagnosis of PSC, they always recommend doing a colonoscopy because a lot of them will have ulcerative colitis. Not everybody who has ulcerative colitis will have PSC. So as we talked about, transmural inflammatory disease, it can affect any part of the GI tract. I don't see it affecting the esophagus or the stomach too often, to be honest with you. I've seen some duodenal lesions. I've yet to see any ulcers in the stomach, but it can definitely happen. I've seen a bunch of patients who have ileal strictures, jejunal strictures, patients who get diagnosed through CT enterography where you find some wall thickening and they have to go and get a surgical diagnosis. So there's three major patterns of disease. 40% of the time, you'll see it in the terminal ileum and the cecum. So that's why it's really important to do a colonoscopy and go into the TI in these patients. 30% of the time, it's just confined to the small intestine. And these patients are the ones that are really difficult to diagnose. You have to have a really, has to be looking for it, basically. And then the other 30% is confined to the colon. So if you have at least a third of the colon involved in Crohn's disease, then they have an increased risk of colon cancer, and their risk, they become high-risk patients. So they need to get much sooner colonoscopies. So TI inflammation is a hallmark location. You develop skip lesions, so discontinuous involvement. Although it's a little tricky. Some patients, you go in there and they're kind of in the middle of like their flare up, and so they may actually have UC, and it kind of looks like they have skip lesions. But again, if you've done enough colonoscopies, you kind of know what ulcerative colitis looks like, and the term ulcerative colitis is a little bit misleading because you would think that there's ulcers scattered throughout the colon, but that's more common in Crohn's. With ulcerative colitis, you just see a lot of just basically like raw inflammation. Crohn's disease looks, for lack of a better term, it looks like Crohn's disease. There's really deep ulcers. They're kind of scattered throughout the intestine. You can have some stricturing disease. So it just looks different. On pathology, non-caseating granulomas is what you see. And then you'll see this transmural inflammation and thickening. And so that's why you'll get these stricturing disease processes. So what are the complications? This patient had a lot of these complications. So he had some fistulae, he had some anal rectal disease. This guy had abscesses and perianal fistulas. Small bowel obstructions are very common. It's the most common indication for surgery. Again, malignancy is a possibility, especially if there's over a third of the colon involved. Patients who have only small bowel involvement, they don't need to have frequent colonoscopies for screening purposes, at least. You could have B12 malabsorption, B12 deficiency, bile acid malabsorption. You can have gallstones, again, because of decreased bile absorption. You can have kidney stones, and then ulcers. In patients who have really, really sort of chronic disease that has gone undiagnosed, you can actually have growth retardation. And then in a lot of these patients, because of everything they've gone through, you can have narcotic abuse, bless you. So I had a patient once, this is actually online, I had posted something about IBD. I think it was about ulcerative colitis. And I said something to the effect of like, colectomy is curative. And I had somebody comment that, you may be getting rid of the inflammation, but the disease is still there. And they started talking about all these psychosocial issues. And I was like, okay, fair enough. Like there is a lot that goes on aside from just the disease process. Because of chronic disease, you have a lot of family dynamics that change. I mean, some of these patients are kids when they're diagnosed, in their teens. So their parents are obviously very worried about them. So when you see them in clinic, a lot of times the parents are there and they're asking a lot of questions. And truth be told, sometimes it can be a frustrating dynamic because you're trying to treat the patient and the parents are very worried and they think that they know what's going on. And so it's just a matter of talking things through. But again, narcotic abuse is definitely something that we see from time to time. And it's just something you have to keep in mind when you see these patients and have a little bit of empathy for them. So how do you diagnose? Colonoscopy is a great way to diagnose. You get tissue, take pictures, and then you can go back later on and see if your treatment has been effective. So typical findings on endoscopy: aptus ulcers, cobblestone appearance, the pseudopolyps that we talked about, and skip lesions. Other things you can do, and in patients that are maybe have other chronic diseases, maybe you don't want to put them through anesthesia. You can do an upper GI with small bowel follow through to begin with. A CT enterography is a great way to look for small bowel wall thickening and ulcerations. You can do a pill cam. The only thing with pill cams is you got to be careful if there's a concern for a stricture, because those pill cams can get stuck at that stricture and then they'll need surgery to get it taken out. And again, patients can have vague abdominal pain and diarrhea for years without getting the diagnosis. And a lot of these patients are billed as IBS before they finally have something that presents itself and something that's available for diagnosis. So the treatment for these patients, you can use 5-ASA compounds. So sulfasalazine is useful if the colon is involved. It's not as great a medicine for Crohn's disease as it is for ulcerative colitis. But in patients who have pretty mild disease, you can start off with it. And if it works, then they get away with just oral therapy. So that's nice. Metronidazole actually has anti-inflammatory properties. So it's not that it's an infection, it's got anti-inflammatory properties. So that can be helpful as well. Systemic corticosteroids, so prednisone, solumedrol. So these medicines by far are the best and fastest way to induce remission, but you're going to have a lot of side effects. So ideally you want to get them on it, get the inflammation down, and then try to taper off and switch to something that's not a steroid. You have your immunomodulators, azathioprine, 6-mercaptopurine, methotrexate. Then you have your biologic agents. And again, there's a lot of newer medicines that have come along, and we'll talk about that a little bit later, but that's good for both induction and remission. A lot of the patients that have IBD will end up being on these medicines long-term. Surgery is reserved for complications of Crohn's disease. So, you really don't want to take them straight to surgery unless you absolutely have to. Typically, they resect the involved segment if there's a stricture. There is disease recurrence pretty high. About 50% of patients will have disease recurrence at 10 years. But if they have small bowel obstruction, if they have fistula, especially when they have colovaginal fistulas, colovesicular fistulas. We actually had a patient just last week that had, she was going to have a colovaginal fistula. I mean, she was reporting stool whenever she'd go to the restroom. So really pretty just pretty bad symptoms. Disabling diseases, and then perforation or abscess, again, indications for surgery. And a lot of these patients will end up needing TPN if they have really bad strictures and can't tolerate oral feeds. So how did this patient do? They were discharged, given prednisone 40 milligram tablets. We checked Hep B serologies, checked for tuberculosis. Everything came back negative. They were doing a lot better when we saw them in the clinic. We're having regular bowel movements. Had gained 10 pounds already, so it almost gained all their weight back. Weren't having any abdominal pain, and we ended up starting this patient on Humira. We also ended up starting patient on Imuran. We did a top-down approach. And so with patients with inflammatory bowel disease, you want to look for the risk factors for disease severity. And so this patient had a lot of risk factors. So he was a young patient. He had really, really severe disease on presentation. And so for that reason, you don't want to start off with like metronidazole. You want to really, really hit them hard. And then if you can reduce it later on, great, but you want to get them in remission as quickly as possible. Because this patient did have at least a third of his colon involved, he will eventually need 1 to 2 year colonoscopies for colon cancer screening. Any questions on that patient? No.
Why did you screen for the tuberculosis? Was it because of the granuloma or just to like rule it out?
So if you start patients on anti-TNF agents, they need to be checked for hepatitis B and for tuberculosis. You can have a reactivation. Okay. Very good. So on to patient number 2. So this is a 21-year-old Hispanic female. The reason for the visit, and this is a clinic patient, the reason for the visit was hematochezia, anemia, and lower abdominal pain. So she had reported 2 years of intermittent rectal bleeding. She said that she would have the urge to have a bowel movement. When she'd go to the restroom, it was just bright red blood. And when I talked to her initially, she said, you know, I have hemorrhoids. Like, I know I have hemorrhoids. I've had hemorrhoids for years. These episodes were associated with lower abdominal cramping. So anytime somebody says that they have hemorrhoids, you kind of think maybe, you know, maybe you do, but if you're starting to have lower abdominal cramping and you know they're pale or you have other findings, you really have to kind of rule out other processes. So she says she's having up to 10 bowel movements a day, all bloody during episodes. Between bowel movements, she says she had the urge to have a bowel movement, but nothing would come out. And then she was becoming progressively fatigued, was having more and more weight loss. She takes ibuprofen as needed for abdominal pain. So when I saw this girl, I saw her with her mom. And I told her before I told her pretty immediately, you don't have hemorrhoids. This is something else. I know what it is. So past medical history, she got a history of anemia. She got a history of anxiety, history of GERD. Her surgical history was pretty unremarkable. Nothing, really hadn't had any surgeries before, no family history of colon cancer. She was a student at UTRGV. She's vegan, and she denies any alcohol use, smoking, or illicit drug use. Medications include Cymbalta, Nexium, propranolol, and Zantac. So her vital signs, she is afebrile, heart rate 60. Her blood pressure is a little bit on the low side, but she's tiny. She's 4'11", 110. So actually her BMI is within normal range. She was pale. That was one thing. That was one of the first things that I noticed when I talked to her. Very, very sweet girl, in no acute distress at all. Was just talking very comfortably, very matter of fact. When you examine her belly, she does have generalized abdominal pain to palpation, worse than the lower abdomen. She had hyperactive bowel sounds, also had voluntary guarding, but not to the extent as the other patient. And no palpable masses in the right lower quadrant were noted. Did do a genitourinary exam, no abscesses, no visible fistula noted, no hemorrhoids. So on labs, the pertinence, she was anemic. Her hemoglobin was 9.3, again, MCV of 69, platelets of 529,000. So those look fairly similar to the other patient. SED rate was 42. And then have you guys ordered, or do you guys know what a fecal calprotectin is? Ever heard of fecal calprotectin? So it's a form of an inflammatory marker, I guess, so to speak. It's a stool test, checks for calprotectin, which is released by white blood cells when they're in your gut. So if it's elevated, that's basically evidence that there's an inflammatory process going on, but it's not specific. So it could be infection, it could be malignancy, it could be ischemia, but hers was elevated at 501. We did do stool cultures, and those were all negative. Iron profile, she had an iron level of 14, a ferritin of 3, percent saturation of 3 as well. So that's very consistent with iron deficiency anemia. And her vitamin D level was also a little bit low at 21. So we checked her for celiac disease. Celiac can also cause iron deficiency anemia, and it can cause diarrhea, but her levels were normal. Checked her B12 and folate, was also normal. And at the time, I didn't think any imaging was indicated. She looked very comfortable. So we ended up scheduling a colonoscopy as an outpatient. Beginning in the rectum, she had loss of vascular pattern, friability, erythema, and ulcerations in a continuous pattern up to 35 centimeters from the anal verge. So we took biopsies. Pathology results showed evidence of colitis, mild to moderate, evidence of cryptitis with crypt abscesses noted. It's hard to appreciate with these pictures, but typically when you do a colonoscopy, it's a little veiny. I mean, you see some veins throughout the colon. It has a very typical appearance. When you get in the transverse colon, it has kind of a triangular appearance to it. In the sigmoid, it's a little bit more twisty, but you should see some vasculature. And in patients who have inflammation, especially when it's diffuse like this, there's so much edema that you lose that, and so that's what's termed loss of vascular pattern. And then if you just kind of touch it with your scope, it bleeds a little bit, and that's not normal in a normal colon. All right. So again, what would point against an infectious cause for this patient? So it's been going on for a while. She's afebrile, I think somebody mentioned. But more importantly, it's chronic. She says it's been going on for 2 years. So the likelihood of this being infectious is less likely. Ischemic colitis, what goes against that? She's young. Yeah, she's young. She looks pretty comfortable. She doesn't have any inciting factors. Didn't become hypotensive during a recent surgery or anything like that. Crohn's disease, I guess, is possible. She's the right age, between 18 and 35. She's got elevated inflammatory markers. Colonoscopy shows a continuous pattern. That's not typical of Crohn's disease, but you never know. Certainly possible. Irritable bowel syndrome. So she's got some, there's some factors that could be attributable. So she does have a history of anxiety. She's a UTRGV, so maybe stresses of taking tests could cause diarrhea, loose stools. But typically with IBS, they're frequent small volume bowel movements, and they definitely don't cause microcytic anemia, so a little bit less likely. Diverticular bleed. So she's a little bit young to have a diverticular bleed. We do see patients from time to time in their 20s and 30s with diverticulosis, but it's not as common. You typically see that in older age. Diverticular bleeds we see a lot in patients who get diagnosed with like atrial fibrillation or coronary artery disease, and they get recently started on a blood thinner, or if they're older and they just have a lot of diverticulum. Less likely in this patient. And the other thing is typically with diverticulosis, when you have a diverticular bleed, it's pretty extreme. And I know she mentions that she has a lot of blood in the stools, but this has been going on for a long time, very, very frequent. Typically, diverticular bleeds are like, boom, it hits you and it looks like a murder scene. I mean, there's like a ton of blood everywhere. I had a husband and wife, and the husband took pictures of the wife like when she was like there laying with all the blood. And it looked literally like a murder scene. Nobody had ever done that. And so I saw it and I was like, wow, okay, thank you. Thank you for that, sir. So yeah, it's really scary for the patient, but and then hemorrhoidal bleeds. I actually have had a patient in ICU who was essentially bleeding to death from a large internal hemorrhoid. She was on blood thinners. This patient, has intermittent bleeding. She says she thought it was hemorrhoids, but what goes against that is she's having lower abdominal discomfort, been going on for a long time, but she also has diarrhea. She has inflammatory markers that are elevated. And again, we have a colonoscopy that shows that she has something other than hemorrhoids. So ulcerative colitis on this young lady. So there's also a form of IBD, chronic inflammatory disease of the colon and rectal mucosa. So it can occur at any age, but typically about 18 to 35 is classic. Always involves the rectum. So when you describe ulcerative colitis, you describe it from the rectum back. And so you say, beginning at the rectum, extending all the way to the sigmoid, extending to the transverse colon, extending to the cecum. In about 10% of cases, it involves just the rectum. And so that's called ulcerative proctitis. Proctosigmoiditis, if it involves the rectum and the sigmoid. Left-sided colitis, you'll see in about 40% of cases. When you have extensive colitis, including the rectum, left colon, and right colon, that's in about 30% of cases. And you'll have pancolitis, which is essentially the whole colon, in about 30% of the cases. Usually will not see any small bowel involvement, certainly won't see it in the jejunum or the duodenum. Every now and then you will see a little bit of inflammation in the ileum. That's something called backwash ileitis. And so the only exception to the continuous pattern that occasionally you'll see is you can have what's called a cecal patch. I don't know if you guys have ever heard of that. If you just kind of look it up, it looks like a little circle of inflammation right around the appendiceal orifice in the cecum. And so you may have inflammation, continuous from the rectum to, let's say, the transverse colon. The rest of the transverse and the ascending look fine, and then you have just this little patch in the cecum. And so that's something that you can also see in ulcerative colitis. So that doesn't mean it's Crohn's. Of course, it's unpredictable, variable. You have periodic exacerbations, periods of complete remission. And that can be the tough thing about treating these patients, especially when they're young. Patients will have this, these severe symptoms. You give them medication, they feel better. They're 21, 22 years old. They get off their medicines, and they get another flare up. And so it's hard to get it sort of through their head that this is something that you're always going to have. You need to keep taking your medicine to stay in remission. Only 5% of patients who have initial attack will not have another recurrence. So you're likely to have another flare if you stop your medicines. So clinical features, this is, if you've seen enough ulcerative colitis, it becomes a pretty obvious diagnosis when you see them in clinic. They always present pretty similarly. It's a lot easier to diagnose, I think, than Crohn's disease. They'll come in saying they've had diarrhea, they're having bloody stools. Someone will describe frankly bloody stools. They won't look as sick in general as Crohn's disease patients. They can have non-bloody diarrhea for a period of a couple weeks, couple months, and then it turn into bloody stools. They'll have abdominal pain, but again, unless it's really severe, it's kind of mild to moderate pain. They can have these rectal dry heaves, which is the sensation that they have to go to the restroom, but when they go, nothing really comes out. So that's called tenesmus. And then your extraintestinal symptoms include jaundice, uveitis, arthritis, and then skin lesions, erythema nodosum. Gosh, I'm blanking on the other one. Whatever the other one is, I forgot it right now. So you can have uninterrupted involvement of the rectum and colon. So there's no skip lesions in ulcerative colitis. Inflammation is not transmural, and so you're not going to see strictures with ulcerative colitis as commonly. And then you'll have PMNs accumulating in the crypts of the colon. That's something called crypt abscesses. So you see that on pathology. So diagnosis, you always want to rule out infection. And even after you diagnose ulcerative colitis, if they come in with what they think is a flare-up, you always want to make sure that they don't have an infection, because just as anybody else, they can get E. coli, they can have C. diff. So you want to make sure before you put them on steroids that you rule out just an infectious cause. So you want to check stool culture, C. diff, ovum parasites, fecal leukocytes, fecal calprotectin. And again, calprotectin is a protein that's found inside neutrophils. And when neutrophils reach the site of inflammation, the cell will disintegrate and release this calprotectin. And so that's what you're checking when you're doing a fecal calprotectin level. So white blood cells can appear in a variety of inflammatory conditions. And so just because this calprotectin level is elevated doesn't mean it's ulcerative colitis, but it's just another sort of piece of the puzzle to diagnose it. And then, or obviously getting a colonoscopy is diagnostic. You can go in there and take biopsies and confirm your suspicion. So you can have a variety of complications, obviously bleeding, iron deficiency, anemia. Strictures aren't as common unless you have severe edema. So again, this is a mucosal disease. So if you have severe edema, then yes, you can develop a stricture. But when you have a stricture in ulcerative colitis, you really want to rule out malignancy. There's a big concern for malignancy in that situation. Colon cancer, the risk correlates with the extent and the duration of colitis. So if you just have proctitis, you actually have a normal risk. So your average risk patient for colon cancer screening. So you begin at the age of 45, just as any other patient. If you have left-sided colitis, and your risk goes up. And you have colonoscopies every 2 to 3 years. If you have pancolitis, it's every 1 to 2 years. Primary sclerosing cholangitis is a possible complication. The course doesn't parallel the bowel disease, and it's also not prevented by colectomy. So you can get going back to that patient that had messaged me. She was right. Just because you get rid of the inflammation doesn't mean the disease is gone. Cholangiocarcinoma. Half of all bile duct cancer is associated with ulcerative colitis. And then toxic megacolon is the one condition that you really want to be aware of. If you have enough severe inflammation, you can develop toxic megacolon and perforation. Growth retardation isn't as common with ulcerative colitis, but can happen. And again, narcotic abuse and psychosocial issues are possible as well with any chronic condition. Yes.
I think it might either the battery is starting or because the voice is kind of.
It's going up and down?
Yeah.
Okay. Let me know. I can just speak louder.
It is batteries, guys, just in case. that right? I don't think it's. Okay.
Can you all hear me okay? Okay. Oh, okay, cool. So medical treatment, again, steroids are the mainstay for acute exacerbations. It's going to get patients in remission. 5-ASA compounds are actually really good for ulcerative colitis. They're preferred over topical steroids. They're effective. And again, you don't have these side effects and you can get remission as high as 93% of patients. So 5-ASA compounds are good at inducing remission and maintaining remission in a lot of these patients. So that's really nice for them. And then if in patients who have distal disease, so proctitis, you can give them things like suppositories, you can get them enemas. Only thing about that is, most patients don't like doing that chronically. And so it's nice to get them in remission, but eventually most patients will want to switch over to a oral compound. And then immunosuppressive agents in patients with refractory disease to prevent relapses. So this patient did quite well. We gave her laude as well as some cord enemas. She did well. She was in remission after 1 month. Her appetite was better. She was having normal bowel movements, no rectal bleeding, and we just ended up continuing laude, and she did well. So we saw her 2 months later. Her anemia had gotten better. Inflammatory markers were all better. And then I saw her, I think, up to a couple of years after the initial diagnosis, and she was doing awesome. So she's one of these patients that does quite well with just oral compounds, doesn't have to worry about doing any anti-TNF agents, at least at this point. All righty, so this is a just kind of a comparison. And so if you guys want to take a picture, this is just a nice little summary of the differences of Crohn's disease and ulcerative colitis. But basically, continuous versus skip lesions. You can have non-bloody diarrhea with Crohn's. Almost always will end up bloody in ulcerative colitis. You have abdominal pain in both diseases. Gastrointestinal manifestations can be seen in both, more often in Crohn's. Onset of symptoms, again, it's pretty obvious when you see ulcerative colitis, bloody diarrhea, whereas it's more insidious with Crohn's, a little bit more difficult to diagnose. If you see any abscesses or fistula or strictures, you got to think more Crohn's disease. Endoscopic findings, again, the term ulcerative colitis is a little bit misleading. You see the deep ulcers with Crohn's, you'll see skip lesions, fissures, and cobblestoning. With ulcerative colitis, you see the superficial ulceration. You have this mucosal shine or the loss of vascular pattern, erythema, and continuous. It's a continuous process with pseudopolyps. Histologic features, you'll see granulomas with Crohn's, and then you'll have transmural inflammation with this creeping fat or fat stranding. You'll see crypt abscesses and just superficial inflammation with ulcerative colitis. And then you have in general, you have a higher risk of colon cancer with ulcerative colitis as compared to Crohn's, mainly because you usually don't see too much colonic involvement with Crohn's disease. But again, if you do have a third of your colon involved, then you have to consider them high risk. Okay, any questions about that patient? Yes, sir.
I'm wondering, what do you say were risk factors that you start for, especially at that age?
So it's right now, at least it's considered to be an autoimmune disease. And so the thought process is that there's some sort of issue with like cell interaction. There's some sort of antigen that's getting between the cells, causing inflammation that you don't normally see in normal patients. So typically the body doesn't get exposed to these antigens, and so it develops an inflammatory response. But in general, risk factors, you have a little bit increased risk of IBD if you have a family history of it. She didn't have that. And so she just, unfortunately, just one of these patients that not necessarily have any risk factors. I mean, being vegan, being female, none of this is a risk factor for IBD. Yep.
Often you see toxic medical down here.
Ooh, I don't see it very often. Yeah, you probably would see that. And again, this is sort of an underserved community, but in general, I think patients are able to get to hospitals a little bit easier. But in areas where you have low socioeconomic status, difficult access to healthcare, I guess it's a little bit more common. I may have seen it once in the last 10 to 15 years. Even in residency, I don't think you see it very often. If they have C. diff in conjunction with ulcerative colitis and it's not controlled and it's not treated for a while, then you can definitely get it. Mm-hmm.
Do you think maybe COVID is gonna exacerbate like patients who end up developing UC or disease?
That's a good question. There during the period of the pandemic, there was a website. I'm trying to remember what the name of it was. But if you went to this website, it would give you up-to-date changes or recommendations for patients with IBD, because the big question was, if these patients get on flare-ups, is it safe to put them on steroids? Is it safe to put them on anti-TNF agents? You're suppressing their immune system. What about COVID? And that was a big concern back then. From what I recall, the recommendation during the pandemic was steroids were really the only medicine that was associated with an increased risk of developing COVID, and it was on doses over 20 milligrams. I haven't checked that website in probably about a year. See if I can remember that, and I'll send it over to Christina, but I'm sure it's still available. Yeah.
Because symptoms for these patients are so like sensitive.
Secure IBD database. That's what it was. Yeah.
Do you see like a lot that are more serious disease possibly because they don't want to come in because they're embarrassed or whatever?
I haven't, to be honest with you. I think in general, most patients come in because they don't know that they have it. And so they come in just saying like, I have diarrhea. So in terms of like, being embarrassed of having the disease, I don't really see it too often. The colovaginal fistulas and those sorts of things, that can be a little bit more difficult, and patients definitely will be a little bit shy. So you have to ask about those things. And that can be very debilitating and embarrassing. And so yeah, but anytime they have fistulas, I mean, so you can get fistulizing disease just from chronic inflammation. We see it in diverticulosis. You can get it from things like UC. You can get it from trying to think what else you can get, ischemic colitis. So if you have any kind of inflammation, you can develop fistulas, but especially when you're thinking about UC versus Crohn's, you really got to think more Crohn's disease.
How often do you see patients that are refractory to like the 5-ASAs with steroids to where you need to put them on an immunomodulator? Is that?
It depends on their severity of the disease. So if they're a young patient and they have limited inflammation, so it's just left-sided and it's mild, they're not really anemic, they're not having a lot of symptoms, not a lot of pain, I don't mind starting them on 5-ASAs to see if they do well. If they're hospitalized, then I would be a little bit more cautious about starting them just on 5-ASAs. I may start them on prednisone first, and then maybe in clinic see how they're doing. If they're doing really well, try to taper off. And so with prednisone, you want to slowly taper off. I see it pretty often where patients will be started on 40 milligrams in the hospital. They give them, the hospitals will discharge them with like a week of prednisone, and then they get seen in clinic 2-3 weeks later, and they've been off medication and they're flaring up again. And so typically when I put patients on prednisone, I'll put them on prednisone as well as maybe mesalamine or something. And then when I see them in clinic, if they're doing really well, then I'll say, okay, well, let's continue this prednisone for about a month. After a month, we'll see again. If you're still doing well, we'll start bringing you down. And so I usually will bring them down at 10 milligrams every 1 to 2 weeks. So they'll be on it for about 2 months, but it's a very slow taper just to make sure that we catch it. So if we go down to 20 and they're starting to flare up again, then maybe just putting them on mesalamine isn't the best treatment, and then we'll start looking towards an immunomodulator or an anti-TNF agent.
Thank you.
Yep.
So patients who are diagnosed with UC at early stage, so is it possible they will get worse when they get older?
Oh yeah, definitely. Yeah, so that's one of the risk factors and predictors for severity of disease. So if it's severe disease as a young patient, then they're likely to get worse as they get older. And so those patients, when you look at the treatment pyramid, you want to do a top-down approach.
So is it also possible that may affect other GI symptoms like system?
Other like extraintestinal manifestations, you mean? Yeah, I mean it's possible, but definitely if they're a younger patient with IBD and they have severe disease, it's a predictor for poor outcome. And so you want to put them on something like an anti-TNF up front. Yep. Also, the risk for colon cancer is increased in patients that are younger. If they're not controlled for several years, and they're more likely to have colon cancer. Mm-hmm.
Got diagnosed by she mentioned what did they do at that time, or why
She thought it was hemorrhoids. And she was actually, I mean, she didn't look that uncomfortable. She was just very, very pale. And so she just kind of tolerated it. I mean, it was, she was in school, she was busy. And her personality was also just, I don't know. I don't think she was all that worried about it, to be honest with you. She was just kind of blowing it off for a long time. I don't think it was out of fear or anything like that. She didn't present like that. She was just very matter of fact, like, hey, my doctor sent me over because, I'm having bleeding. I know it's hemorrhoids, but I'm here. So yeah. Okay. All right. So going over the treatment options that are available today. So lots changed, especially in the last couple of years with regards to treatment options. And we'll just go over this very briefly. Won't go into too much detail, but we've talked about steroids, best medication to induce remission in both ulcerative colitis and Crohn's disease. You definitely want to try to wean them off very slowly. You eventually want to get them off. It's, no good to have these patients on chronic steroids so they can get necrosis of their bones. You can get obviously diabetes, hyperglycemia. You can get anxiety. You can have difficulty sleeping. You have issues with cataracts. But there's just so many complications of steroids, osteoporosis. So good for inducing remission. Try to get them off as quickly as possible. 5-aminosalicylates, so things like Lialda, mesalamine, sulfasalazine, good for UC, not as much for Crohn's. There's very few side effects. Really, I think the only recommendation is to check a creatinine once a year, which that happens on its own. Good for induction and maintenance of remission. Again, useful for patients who have mild, maybe mild to moderate disease. And if you're able to maintain them on that, then that's awesome for them. Immunomodulators, so things like azathioprine, 6-mercaptopurine, which is essentially the active metabolite of azathioprine. They're good to maintain remission. They're not good to induce remission. So these medications actually take up to a couple of months to take effect. So what you don't want to do is put these patients on azathioprine to get them in remission and then have them follow up in a couple of weeks because it's not going to do anything. With these patients, you do have to check TPMT level to make sure that your body can metabolize these medications. And we always recommend checking LFTs, typically within the first month or so. Start with the lowest dose, maybe 50 milligrams, and see how they do. You can go up to 100 milligrams if you still need a little bit of improvement in their symptoms. Methotrexate has been used in the past. Definitely not something that you recommend in a patient who is looking to have children. It's a Category X drug. And then your biologics. So this is where all the medicines have come out here recently. So traditionally you had your Cimzia, your Humira, and your Remicade. But now you have things like Skyrizi, which is used for Crohn's disease. You have Stelara, which is useful for Crohn's and ulcerative colitis. And so those aren't anti-TNF. Those are actually anti-interleukin medicines. You have your anti-integrin medicines like Entyvio and Tysabri. And then you have your JAK2 inhibitors, which are both oral medications, and they're useful for ulcerative colitis. One of my attendings from Scott and White actually may be coming down to talk to us soon about Rinvoq, which I would love to hear about because I know kind of just the surface of Rinvoq. It's so new. I think it was approved for UC last year, and so and then Xeljanz I think has been around for a couple of years for ulcerative colitis. It's been around and it's been used for other disease processes, rheumatoid arthritis, but just got the approval for ulcerative colitis a couple of years ago. Alrighty, guys. So this is me. This is where you can find me. Hopefully not as a patient, but you're welcome to see me as a patient. But if as you guys get through your training, hopefully you'll stay in the Valley. I won't hold it against you that you're not from Mac High, but that's okay. But hopefully we'll see it at DHR or somewhere in the Valley, taking care of the patients of the Rio Grande Valley. And definitely feel free to give me a call. I'm happy to see any patients y'all send my way. And then I do have social media that I try to post some information there from time to time. So thank you very much for giving me the time. Appreciate it.